Good evening, one and all. At the outset, first of all, I would like to thank Dr. Manish Pandey for giving me the opportunity, and the West Zone Coordinator, Dr. Kinjal Jani, for this opportunity. And more importantly, it is important to join and see everybody today and have a great discussion on this meeting. So I have a very esteemed panelist with me today, Dr. Ashish Bhaiya. Maitri, just let me know who are not there in the panel so that I don't repeat their names while asking the questions.
So you can take a, Pooja, you can take attendance of.
Oh no, Bhaiya. So if I open my video, I will definitely look like a teacher only. So that's why I'm not opening also my video. Anyways.
You're always teacher for us.
That is not allowed.
That is not allowed? Okay, fine. So
no, she's always teacher for us.
अच्छा ओके चलो अच्छे से हलाल करने वाले हो सब ऐसा लग रहा है मुझे. So I have the esteemed panelist as Dr. Ashish Kumar, Dr. Maitrik Mehta. I can see Maitrik Bhai. Dr. Mehul Goyal is not going to join. He is a little bit busy in some function. Dr. Samir Batam is very much with us. Dr. Suruchi has some medical issues, so probably she will not be able to join. Dr. Triranjan, I am not sure. Dr. Vaishali Shinde, Dr. Vikas Kotwade. So
yeah, I am very much here.
Okay, Triranjan. Hi, how are you?
Hi, I'm good. How are you?
Good. So welcome all the esteemed panelists. And so we start. Now, I have been given a very tough topic, biochemical recurrence after definitive RT. So in fact, it is not tough for me. It is tough for my panelists to decide whether it's a biochemical recurrence. My slides are not moving. So give me a minute. I'll stop sharing and reshare again. Just give me a minute, please. Is it moving?
No.
Okay.
Ma'am, we can't see your slides.
You need to share.
Yeah, I am resharing. Just give me a minute.
Ravindra ji, Ashish is not there.
कम लोग हैं, ज्यादा सवाल
No,
मत
sir.
पूछना भाई. सारे क्वेश्चन मैत्री को पूछ रहा.
मैत्रिक तो इसी में खुश हो जाता है.
मेरी स्लाइड आप दिख रही है फुल स्क्रीन?
Yes,
ma'am.
मूव हो रही है?
Yes.
Okay, fine. So this topic being such a little bit weird, I think I need to clarify certain points before moving ahead. So how to define biochemical reference? Is it the same post RP or post RT? What are the tools to decide whether it's a biochemical recurrence? When do we decide we have to treat? And if we decide to treat, how do we treat? So these are the difficult points, I think, and we all should be first answering these points rather than jumping to the two cases which I have. So I'll start with the definition of biochemical recurrence. So I see Samir. Samir, can you please let us know that how do we define biochemical recurrence?
Yeah.
Hello everyone, and so when we talk about the biochemical recurrences, so as per the Phoenix definition 2006, which was later modified by Astro and the nanogram per ml or more, this is considered biochemical recurrence. But when we talk about post-radical prostatectomy patients, there is slightly difference where ideally it should be undetectable post-surgery, and if it is detectable after surgery, this is considered biochemical recurrence after surgery.
So, Maitrik Bhai, do you have the same opinion, or you have some different definition of biochemical
Actually,
recurrence?
after radiation, if we consider for biochemical recurrence, there are two ways. One is clinical practical definitions. And another is actually, hello, am I audible?
Yes, Maitrik Bhai, you're audible, but I would request the other people to please mute themselves. When I ask them questions, they can unmute themselves. Yeah, Maitrik Bhai, go ahead.
So there are two ways. If after radiotherapy, we need to consider for PSA nadir first. And after PSA nadir, if there is 3 consecutive rise in PSA level, it is called as one biochemical recurrence. Another point is that as a clinical definition or a practical Astro guidelines have suggested, it is 2 nanogram per ml rise. That is called as biochemical recurrence. In post-radical prostatectomy, usually they consider as a 0.2 nanogram per ml after surgery, which is called as biochemical recurrence. And initially it was, and sometimes in practically it is used as 0.4 nanogram per ml. another thing is that if after radiotherapy, there is a phenomenon called as PSA bounce. So up to 12 to 18 months, usually there may be chances that PSA may range between 0.1 to 5 or 15 nanogram per ml. Actually, after 12 to 18 months, they really stand that if PSA has come to nadir level, and then there is a rise in PSA for 3 consecutive levels, then actually it is called as biochemical recurrence.
So, Maitri, you have given such an elaborate definition. Let me ask you two another questions. When you say the PSA bounce, what is the time? What is the cutoff of this PSA bounce you are defining?
No, there is no actually cutoff of PSA bounce in reality. Actually, usually what they have seen that after radiotherapy treatment up to 12 to 18 months, they have seen the range like 0.1 to even 15 nanogram per ml, and then it has come decline.
So probably you want to say it is the first 1.5 years where this phenomena of PSA bounce can happen.
That may happen. That may happen. And biochemical recurrence actually people stem usually after 18 months. But another thing is that if PSA has come to the nadir level, suppose 0.001 or 0.002 nanogram per ml, which is undetectable. And after with repeated PSA screening, suppose after 3 months the PSA, if it is rising up to 3 consecutive rise in the PSA level, that is called as biochemical recurrence.
What about those patients who have been given radiation plus hormonal therapy? Is the definition same?
Actually, in books it has been written that there is no real variation between EBRT or EBRT plus hormonal therapy. Usually it's same.
Okay. So any of my other panelists would like to define more of this, or shall we move to the next question? Dr. Triranjan, Dr. Vikas, anybody would like to comment?
So there's a big change actually. Both of them are right. The recent AUA or UAU, if you see the American or the European guideline, so they have modified recently, since we have now ultra sensitive PSA detection. So for post RP, post radical prostatectomy, it should be less than 0.1. That is the definition of undetectable. Now, for clinically stamp, it should go more than 0.2, but between 0.1 and 0.2, if you can pick up, even if there are 2 consecutive rise, like say more than 0.1, say 0.15, then 0.18. So it is still not reaching 0.2, but maybe it can be called as M0 CRPC, something like. You will not find anything in maybe a supplementing with an imaging that I know we'll come to it later. But there is a bit of conflict to call it M0 CRPC or not. Some guideline call it as to be M0 CRPC, because then you can have some treatment options to institute early.
So I think while preparing for this panel, even I had to, be very clear what really stamps as a biochemical recurrence, because there's a lot of confusion. And this is what I can summarize for all the panelists and for all the viewers who are there. That of course there's a difference between stamping a post RP and a post RT, the concept of BCR. As Maitri very correctly said, there is a PSA bounce which is nearly seen about first to 2 years after radiation. So a biochemical recurrence, if you're stamping it after radical RP, is around a rise of 2 nanogram per ml or more above the nadir PSA after the radiation therapy. And for the post RP, it is a 0.2 nanogram per ml. And to add more to confusion, there is a situation where we have post radiation plus hormonal therapy. So there are guidelines by the Phoenix criteria, as Dr. Samir was mentioning, and the Astro guidelines, even Triranjan was trying to highlight. So for the post RT BCR, if it is for the Phoenix criteria, it is about a rise of about more than or equal to 2 nanogram per ml above the nadir. But the Astro guidelines says it is about 3 consecutive rises in the PSA level above the nadir, which can be used both in the RT subgroup or the RT plus ADT. So I think we should not have more confusion. We'll go with the live cases that will become more easier to understand. Now, coming to Dr. Vikas, what are the tools to stamp these cases of biochemical recurrence? So how do you say when you have a patient who has been treated, say we are trying to put this panel as post radiation. So if you have a patient of post radiation and what do you would like to have as a set of investigation to stamp it as a case of biochemical recurrence?
Yes, we all know before PSMRI we used to do the MRI or the bone scan, but now we have the biochemical imaging, that is PSMS scan. So we have to do the PSMS scan. So that will show the local as well as distant status of the disease, and more importantly, you have the PSA definition before proceeding to any imaging, and we have to do the biopsy. If the biopsy shows the there is a positive for malignancy, then that is the hard and fast rule that we have to stamp as a biochemical recurrence.
So we have Dr. Vaishali with us. Dr. Vaishali, are you agreeing for getting even a biopsy for all cases before stamping it as a BCR and treating it?
No, first we have to assess what is the, instead of biopsy, first we have to assess what is the serum PSA level plus serum testosterone level, and then radiological investigations. Then if there is any lesion, that it should be biopsy.
But is biopsy indicated really?
Yeah, you have to differentiate between if the metastatic diseases, you have to differentiate it is a squamous cell, sorry, a small cell component or a adenocarcinoma.
So, Triranjan, do you agree for getting a biopsy in all cases before starting the treatment? If you suppose good PSA defining as a case of recurrence and you have even the imaging to support it, do you still warrant a biopsy before starting the treatment?
Not really, to be honest. Maybe the biopsy I would need if the PSA doubling time is less, because that might indicate an aggressive biology, maybe a change in biology. If it is coming, say, after a 2 years, 2.5 years, with a properly done PSMA where you can define the disease, I don't think there's a mandate in any of the guidelines that you have to do biopsy, because there are its own risk doing a biopsy, which may be more disastrous.
And what about your opinion regarding the very standard imaging which you will be using it for stamping it as a biochemical recurrence?
PSMA PET CT.
PSMA
I think
PET
that in prostate is the only site where we have at least one-stop solution. So it should be PSMA PET CT.
Any other panelists who would like to differ or would like to add some point to this? Okay, so now the question it comes is, having stamped it as a biochemical recurrence, how do you decide for treatment? So I will start with Triranjan first.
So there are certain factors before deciding the treatment. One, whether it is biochemical plus radiological, so then that will differentiate whether it is an M1 or an M0 CRPC. If it is an M0 CRPC, then it also depends what is the PSA doubling time, because that is in any guideline you see, that is one key determinant factor. Generally across literature, it is around 10 months or more than 10 months. Then also we take into other clinical factors like age, performance status, so on and so forth, and then decide on treatment. If it is an M1 CRPC, then again, it's a completely separate thing depending on where all we have the radiologically disease, whether it's local, nodal, or both, or also distant metastasis. And then depending on the treatment options.
So Maitri, a final 1 minute take from you, how to decide, to when to start the treatment before I start taking my 2 cases. Maitri,
So if it is biochemical recurrence, then first time that the definitions which you have written, whether the patient suits in that, and we can stem first as biochemical recurrence, then we go for PSMA PET CT scan. And we will see that if it is local recurrence or a distant metastasis, then we will treat accordingly.
Okay, so I think we have enough discussion on this, and probably we'll start with the case so we decide how do we treat for this. So he is a very young gentleman, 72-year-old male who has a complaint of increased frequency of urine. So very quick, because this is a primary case, so I would like to have a discussion more on the biochemical recurrence. So Triranjan, very, very quickly, how would you investigate this fresh case?
Per primum, you mean?
Yes.
So, of course, I would prefer that patient should have a multiparametric MRI before sending for biopsy, because there's ample evidence, then the guided biopsy becomes easier. So once the multiparametric MRI done, other than routine blood test, of course, a PSA, and then send for biopsy, get the biopsy should be 12 core, get it reported properly, come back, depending on then the risk stratification. Probably in Mumbai, we end up doing also PSMA because one patient also wants, and we have also realized instead of doing a bone scan, you don't pick up node in that, you don't see the viscera. So better also do a PSMA PET CT, have a complete staging workup, and then decide on the treatment.
Dr. Vaishali, do you agree to this, or you would like to differ, or you would like to add something?
Yeah, ma'am. Prior to any investigation, we have to I advise to consider for the serum PSA level. accordingly, because you have to rule out any another conditions associated with this. Okay, first PSA, then followed by MRI, then biopsy from that.
So, Dr. Vikas, not wasting much time, say suppose this is a very confirmed case with a biopsy of adenocarcinoma, Gleason score 7, MRI is a clinically T2C N0, PSA is 14, we had a PSMA scan and there is no distant metastasis. How would you like to treat? Would you like to go for surgery or radiation?
What is the age of the patient?
72.
Yeah, so I will go with it is intermediate risk disease. So we'll proceed with a definitive radiation. If the patient is fit, physically fit, and we're expecting and no comorbidities, then we expect the life expectancy more than 5 years. So in such cases,
You would like to add hormonal therapy to this?
No, not required.
Anybody who is of the opinion of adding a hormonal therapy, ADT?
Yes, this is.
I would probably so I would like to know also number of codes positive among the code biopsied, and the Gleason primary versus like whether it is 4+3 or all, that is determined between favorable, unfavorable. Unfavorable,
Yes,
then
Okay. And
then
would your
should be.
radiation volumes would change if it was a clinically a node positive also, or radiologically node positive?
Yeah.
Yes, if it is a
Yes.
strong PSMA positive, I would discuss with our nuclear medicine. If it is suspicious, then yes, we have to then probably I'll wait for more hormone, maybe at least 6 months, repeat a PSMA. That PSMA response would guide the volumes. Like node definitely need to be treated, undoubtedly. Whether node as post-hormone PSMA negative, so then as elective, or post-hormone still PSMA avid residual node, then the node also warrants boost.
Okay. So, Dr. Vaishali, very quickly, if this patient is finally treated for radiation plus ADT for 6 months, how do you evaluate post-radiation? Because now we have to start the main discussion. How do you evaluate?
We are going to consider for the PSA 3 monthly, or ideally it should be 6 monthly. Then that is the thing, we have to take care of that.
Dr. Vikas, if I show you these reports, that post-treatment, his 3 months report was 0.04 nanogram per ml. And would you be ready to start the imaging, or would you wait for a PSA to see how it is going serially?
Yeah, we'll wait for the PSA to increase. And if it's doubling, we are seeing, then we'll ask for the PSMA scan.
Okay, great. So probably this patient was doing well, but 2 years later with serial PSAs every monthly, because now it was showing a rise. So the serial PSAs were like 0.08 to 0.04 to 0.4 to 0.8. So I think we are now ready to start our set of investigation. Mehtabi, how would you take the case from here?
From here, ideally we should do PSMA scan.
Okay. So
Then
you doubt it's a case of BCR?
Yeah, this is biochemical recurrence. This is and as our previous discussion, we can see that a year after 2 years, the level is 0.8, 1.8, 2.5, and 3.4. So now we can go ahead with the PSMA PET CT scan, and we can see that if it is localized disease or metastatic disease.
So Dr. Vaishali, I hope I am not missing any of the panelists. Dr. Ashish is not there, right, Ravindra? So, Dr. Vaishali, how do you decide for the treatment? Are you ready for it? And if you are ready, what options would you give to the patient? He's a post-RT plus ADT.
Okay, that he failure after 2 years. We can again second line of means second as a ADT first. Then if a patient is presented with distance lesion or visceral mets or spine mets or anything, we can plan accordingly.
So I give you a situation. He has just a local recurrence. He doesn't have any even nodal metastasis or any distant metastasis. How would you give him an option of the treatment for him? How would you decide?
I would still opt the ADT, means ADT as a first line.
So, Dr. Vikas, if I ask you this question, and if you're agreeing to Dr. Vaishali, or would you like to give him some option of local surgery?
If the actual patient's age is 74 and after 2 years is 76, if his fitness is there, then as it is only localized disease. So, and if you see within 2 years, it is started doubling 0.8, 1.8. So it's, even 2 years is not a much time. So local treatment should be offered if patient is physically fit.
Dr. Triranjan, you agree or you have some different opinion?
No, I agree with Vikas that local treatment option should be sought for. So they have to meet neurosurgeon whether surgery is feasible. Though with the age and extent, that may be a challenge. But local treatment option, if surgery is ruled out, then we can see with second line ADT and then reevaluate after some time.
But in prostate, if there is biochemical failure and if it is local recurrence, then after 2 years, is surgery recommended? Because radiation also will have some implications in prostate also.
Yes. It's very doubtful. It's practically very doubtful, but because traditionally, like any local recurrence, there should be a surgical salvage option at least taken. If you see also any local recurrence post RT, especially the options are very query. There's also even an option in both AUA and UA guideline that if patient is non-symptomatic, you can still observe as well. That observation factor is also there post RT local recurrence to see in further PSA. So
in prostate cancer, in salvage surgery, usually they don't recommend.
They don't recommend. Yes, they don't recommend. So I think maybe to discuss again in multidisciplinary, and if a second line hormone goes on and disease control, then the local retreatment option is also there. There are multiple. There are systemic review published now of a retreatment option, and where the median actually is 2 years.
But suppose local retreatment means maybe re-radiation.
Yes.
It would be only after 2 years, and this patient must have received 78 gray of dose.
Yes.
From the first outset.
So actually, there's a systematic review published just some time back in Red Journal for quite a long time treated. The median treatment time, if I recall right, is around 4.5 years, but the range was from 1 year to around 10 years or so. There is bit increase in grade 3 GU as expected. But if it remains after the ADT, if remains controlled, that's the best scenario. Even people have recommended intermittent ADT also. It may not be continuous.
Now my questions will be very clear to both of you because you're so aggressive on this patient. Triranjan, if I tell you that if you're ready for a post in a biochemical recurrence, you're ready for a re-radiation, what would be your ideal way of giving a re-radiation?
I would probably start with hormone, second line, follow it up.
I am telling you, you emphasized for re-radiation. So what would be your ideal way of giving a re-radiation? Would be a external or a brachy or what?
Theoretically, both options will be looked for. Frankly, if I tell you, I don't have any experience of doing prostate brachy, so for me, it would be external.
Okay. Now, Maitribi, you were very much worried for the post-surgical complication. Please let me know what are the surgical complications you're expecting. Say, suppose he's a fit patient. Let me please understand my question. He's a fit patient. Don't look at his age. Age is just a number. He's a very hale and hearty person, and he's ready for a post-surgery, post-radiation salvage surgery. But you, being a radiation oncologist, don't want to let him go for surgery. So, what are the complications you would make him understand?
No, I don't want to let him undergo surgery. But what has been reported is post-radiation fibrosis will be there, and for surgeons, it is also difficult to remove this prostate gland, and there will be a very difficult surgery for them also, and even for those 74 years. There is no issue of sexual dysfunction or any related complications. But usually they don't recommend salvage prostatectomy in case of radiation failure. They recommend hormonal therapy and local re-RT, so I won't give at all EBRT after 2 years.
एक बार तो एज को इश्यू बना रहे हो, एक बार सेक्सुअल डिस्फंक्शन बोल रहे हो, डिसाइड कर लो पहले क्या करना है.
Hormonal therapy only. As far as
and is it a continuous one or intermittent?
Usually intermittent, and then we can observe.
Chalo, okay, fine. No more discussions on this. We straightforward go to the second case. He's a 65-year-old male complaining of blood in urine, increased frequency, burning micturition. His prostate biopsy is adenocarcinoma, Gleason score 8. His MRI shows T3A with N+. Has one osteolytic lesion at the right pubic rami, PSA 35. PSMA scan is the same. I mean to say there is no other distant metastasis except at this pubic rami. So how do you treat? Triranjan, you consider this as a distant metastasis or a local invasion, and how do you stamp as the case first primarily, and how do you treat? A quick answer.
Okay, quick answer. This is M1, low volume, oligometastatic, should be treated with curative intent in today's time. Hormone,
very good.
Hormone, reassess at least after 2 doses of hormone, depending on your frequency. what hormone you're choosing and all. Intermittent PSMA, see the PSMA response, accordingly then treat local as well as metastatic directed therapy.
Excellent. Samir, are you there?
Yes, yes, ma'am, I'm here.
Samir, how would you take this case? Are you okay with Triranjan?
Yes, I agree with Triranjan. I would definitely start with hormone. I will see how is the response and will definitely consider him for radiation afterwards.
Dr. Vikas, if you agree, what would be your choice of hormone therapy?
Yeah, it's a leprolide base. I will prefer every 3 monthly. That is my preference.
Probably how many cycles?
I will minimum 2 or 6 months I will give, and then I will reassess. If it is, I will be able to do radiation after 6 months, I will proceed with radiation.
So Dr. Vaishali, I give you a case like this. He's been started with hormone therapy. Post 3 cycles, he shows excellent response. Probably the pubic rami in the PSMA repeat scan shows is burnt out. Then how would you treat? Would you still consider only the local prostate and the nodal part to be treated with radiation, or you will give SBRT to the pubic rami also? Dr. Vaishali.
We are planning primary radiation, primary tumor plus nodal irradiation, simultaneously SBRT to the pubic area. But that pubic area is within the field size. We have to we have to find out how much dose that patient is getting during the extra radiotherapy. Simultaneously, we can boost to the bone met cells.
Very good, excellent point. So now post treatment 2.5 years PSA control, but now again the PSA has started to rise. How do you investigate, Dr. Triranjan? Triranjan, are you there? Dr. Maitrik Bhai.
Yes, please.
So you had treated this patient and patient has responded very well. And yes, Triranjan, you're back. Did you get my question, Triranjan?
Sorry.
Yeah,
no, I just missed this. A call came. Sorry.
So I said finally after post radiation, post 2.5 years of radiation, PSA is controlled, but again it has started rising. How do you investigate and how do you start for the treatment?
So investigation would be, again, we'll have to do a PSMA PET CT. And then depending on, it's 2.5 now. So PSMA has localized
and now it is 2.5. Yes.
So of course it is biochemical recurrence, but no nodal, no distance. So it's localized again. So probably, yes, second line hormone to start with, like the previous case.
So he is young comparatively to the first patient.
Yeah, he's comparatively young. Yes, yes.
So would you like to go? You would like to give a surgical option? You would like to give a cryotherapy option or not?
Frankly, I'll tell you, I'll be very honest. In any panel, we should be practical also. I have not seen a single cryotherapy people going, or this HIFU also. I have never ever seen. I have only read in textbook.
Okay. Anybody who has experience of that? Because it's a very honest answer coming from Triranjan. Anybody who would say that he has seen patients treated with HIFU or cryo and they would agree to go for it?
No, ma'am. No, ma'am.
No, ma'am.
Okay, fine. So I think we had a good discussion. Probably any role of, by chance, because we don't have a medical oncologist, any other role of chemotherapies, MABs in such cases? Or any of the points you think I have missed and we should discuss?
Probably because he's less than 70, we should do BRCA and check for option of apalutamide.
Okay.
Because that is also now a category 1 recommendation in M1 disease.
Okay. So Manish bhai, I think I am very much on time, and probably I would like to conclude over here that management of the patients with BCR after the definitive local therapy is still sometimes very complex. And
but
most
you have
of
done
the time,
it very well, Dr. Pooja. Sorry to interrupt. You kept slides very well. I was so happy seeing it. We finally discussed something which is very, very pertinent.
Thank you, Triranjan. Thank you for your inputs also. So, to conclude, most of these people, they usually sometimes die of other disease rather than the prostate disease. So it is very important to first define the PCR, how to treat. And there has to be a risk-benefit ratio of each intervention to be decided before we decide that we have to go for treatment. Of course, as we discussed, there is sometimes even option of observation in such type of patients who have a localized disease, or intervening and then deciding what would be the best option for him. And for those patients who have a high risk of failure for salvage therapy, should be offered either immediate ADT or delayed, and depending upon the predefined PSA value or metastasis. So I think this is all for today's panel. I am very much thankful once again to all the panelists who have joined from their busy schedule and gave their excellent inputs. Maitrik bhai, Triranjan, Samir, Vikas, Vaishali. A great thanks to all of you, and Dr. Manish bhaiya for the opportunity.